Hi, we are Team 33 and our topic for today is polycystic ovarian syndrome. Our team consists of me, Lavinia, Molly, Alicia, and Erin. PCOS is a condition of excess androgen productions from the ovaries which is triggered by inappropriate secretion of gonadotropins. Excess androgen causes anovulation. 4 to 8% of women of childbearing age has PCOS. PCOS is estimated to affect 20 to 21% of women. The exact cause of inappropriate secretion of gonadotropins is unknown. PCOS is genetically linked. For example, those with PCOS are more likely to have mothers and sisters with PCOS. The reproductive cycle is regulated by changing hormone levels produced by the pituitary and the ovaries. PCOS alters level of FHS and LH. FHS is follicle stimulating hormone and LH is luteinizing hormone. The pituitary gland secretes high levels of LH. This causes the ovaries to produce excess androgens, for example, testosterone. Androgens are converted into estrogens and increased level of testosterone causes an approximately 50% reduction in sex hormone binding globulins. Excess androgens prevents follicular development. FHS decreases and continues to be present in small amounts. Follicle development continues but maturation of the follicle does not take place. Chronic anovulation produces bilaterally distended and polycystic ovaries. Elevated estrogen level triggers a positive feedback response in LH and a negative feedback response in FSH. Relationship between high androgen levels and insulin resistance. Insulin excess promotes excessive androgens production by the ovaries. This reduces sex hormone binding globulins directly and independently. The degree of frequency of hyperinsulinemia is amplified by obesity in women. Insulin synthesizing hormone have been shown to promote ovulation and ultimately pregnancy. Signs and symptoms of PCOS are menstruation non-uniformity, prolonged menstrual period and intervals less than 8 periods per year, overproduction of androgen which causes hirsutism and acne, anabolic states, it leads to obesity and difficulty in losing weight, hypertension, acanthosis nigratis, which is the darkened thickened patches, and velvety skin near armpits, thighs, and hands.
Ultrasound is highly sensitive and specific, which makes it ideal for assessing the ovaries. It is widely available and a cheap alternative to other imaging modalities, and there is no exposure to ionizing radiation. When examining the ovaries, transabdominal and transvaginal methods may be used. TV is the preferred method of imaging when screening for PCOS as it provides optimal visualization of the ovaries. This is due to the higher frequency of the TV transducer, requires less depth of penetration, and can bypass attenuating soft tissue. It's noted that 30% of women who have PCO go undetected when transabdominal is the only form of ultrasound used. What is required of the patient? It is recommended that women with regular menstrual cycles book between 3 to 5 days of their cycle, as this is the optimal time to image developing on follicles. Women who experience irregular cycles or do not bleed can be scanned at any stage. A TA scan will require a full bladder, whereas a TV scan will require an empty bladder. Informed consent must also be given. For TV imaging, a curvilinear or linear probe are to be used at as high a frequency as reasonably possible without loss of depth of penetration. For a TV scan, a disinfected sterile TV transducer should be used, should be covered with a sterile cover such as a condom, and the use of lubricant to assist insertion into the vagina. For TA imaging, the patient will predominantly lay supine. TV imaging will require the patient in a lithotomy position. This can be assisted using stirrups or a cushion underneath the buttocks to abduct the hips. For a TV scan, place the probe tip within the anterior or lateral vaginal vortex. Apply a firm pressure against the vaginal wall. Rotate and angle to the sides to orientate the image. Surveying the ovaries in long axis and then short axis by rotating the probe 90 degrees counterclockwise. Ensure to sweep through the ovaries inferiorly and superiorly, and record the ovaries volume and the largest follicle size in all 3 planes. If you are still struggling to locate the ovary to perform your survey, apply some pressure to the anterior abdominal wall using a non-scanning hand, as this may assist sliding the ovary out from underneath the bowel. When performing the TA scan, place the probe in a transverse plane slightly right of the midline and angle left laterally. This will bring the left ovary into view and ensure the surge of the ovary in two planes before moving to the other side.
Polycystic ovarian syndrome is best defined by the appearance of follicles and the volume of the ovary. The sonographic appearance of polycystic ovarian syndrome presents itself with more than 12 follicles within the ovary measuring between 2 and 9 millimeters and a volume of the ovary of 10 cubic centimeters or 10 millimeters. There is also a dense hyperechoic stroma and a string of pearls appearance. As can be seen in the image above, the ovaries affected by PCOS are more hypoechoic and the cysts appear anechoic. They generally also appear along the borders. The diagnosis of PCOS can be done through laboratory findings as well as ultrasound images. The lab tests done are used to test the levels of hormones, cholesterol and triglycerides in the blood. Sonographic diagnosis is done through transabdominal and transvaginal ultrasounds. While the transvaginal ultrasound is generally not used on minors or on people who have not been sexually active. Ultrasound enables us to diagnose the cysts, measure the cysts, and then compare between both ovaries. The differential diagnosis of PCOS can be done by assessing the symptoms as well as looking at the images. By just assessing the symptoms, you can see that there may be hypothalamic amenorrhea, premature ovarian failure, idiopathic hirsutism, Hare-Ann syndrome. And looking at the images, there can be neoplasms in the ovary, adrenal glands, pituitary and hypothalamic, as well as multifollicular ovaries which have fewer cysts that may be bigger than 10 millimeters. The treatment of PCOS can be done through low dosage birth control pills, anti-estrogen medication used for women who want to fall pregnant, management of precursors such as obesity, high cholesterol, hypertension and diabetes, as well as laparoscopic laser surgery done to remove the follicles.
When a pelvic ultrasound is conducted, there are a number of legal requirements which need to be met. For the sonographer, there's a responsibility to adequately explain the procedure to their patient so that the patient can then give informed consent. The sonographer then has a responsibility to conduct a thorough scan and to uncover any pathology. The physician has a responsibility to examine images that were produced during the exam and to provide follow-up to the patient based off these images, as well as to set the patient up for further tests to determine a definitive diagnosis or to set the patient up for treatment of their condition. The patient has a responsibility to understand the procedure and give their informed consent for the procedure. When we're considering transvaginal ultrasounds, however, we need to pay special attention to consent because of the intimate nature of the scan. Generally, we require written consent for this type of scan, and a chaperone is usually made available to the patient. Many clinics will actually only allow female sonographers to perform these scans, and the clinics which do allow males to perform it will generally always provide a female chaperone to the patient. The documents which are relevant to PCOS are generally just going to be a standard pelvic exam worksheet. However, the parts of this worksheet which are particularly relevant are the family history, medical history, clinical indications, pregnancy history, last known menstrual period, and ovarian size and appearance. This is just a standard pelvic exam worksheet, and I've highlighted the areas which might be relevant to PCOS. So we have the patient history here, such as gravidity, parity, last known menstrual period, type of scan, the appearance of the right ovary and the appearance of the left ovary, as well as a diagram at the bottom where the sonographer will draw any lesions or masses or cysts that they find during the scan. So there are a number of complications associated with PCOS, notably an increased risk of pregnancy-induced pathologies such as hypertension, preeclampsia, gestational diabetes, mood disorders, depression and anxiety, and an increased incidence of endometrial cancer, though it's not entirely clear if this cancer risk is directly associated with PCOS or associated with the obesity which so often comes along with PCOS. Finally, infertility was considered to be a side effect of PCOS for a very long time. However, more recent long-term studies have shown that fertility rates between PCOS patients and controls are relatively similar. So in conclusion, PCOS is characterized by more than 20 immature follicles measuring less than 10 millimeters in one or both ovaries. It has no known etiology and is associated with a wide variety of signs and symptoms related to the elevated androgen levels which come with the disease. It's diagnosed with a combination of ultrasound, clinical indicators, and blood tests. However, transvaginal ultrasound is generally the most accurate modality for diagnosing this condition.